Okay. Thank you. Good evening and welcome. Today we are going to be talking about a brief intervention. So let me share my slide and we can continue from there. I hope you can see my slide.
Yes, perfect.
Okay. So today, as I said, we are going to talk about brief intervention, but I want to welcome you back again to our presentation. Today we are going to talk about intervention, and it's not assessment as we carried out last time. After the assessment, if you recall, we were able to administer the assist, and then we start scoring all of us where there were problems. We were able to resolve them, going through the questions and items one by one so that we're able to clarify every confusion in the scoring. And you recall that the assessment is not, administrative assist is not something that you can give to a client and say, okay, just complete this and give me. No. You have to be able to interview the client, you have to motivate, you have to make them comfortable, you have to be able to establish rapport with them before you begin the interview. And then all the response cards that Beatrice gave, you should be able to give them one by one and then explain everything to the client. Then when you score the client and you are able to give a feedback, then you can do your brief intervention. But we'll get to know how you can do some of these things, as we continue. So thank you for being active participants, and thank you too for carrying out your assignments. I really appreciate the active participation and the enthusiasm that you have shown. So today we'll be talking about brief intervention after administering the assist. What next? So what is brief intervention? Brief intervention is low intensity, short duration counseling. Remember, it is low intensity, short duration counseling. And effective brief intervention includes use of empathy and respectful approach. You must be able to empathize with your clients. You must be patient. You must be able to give them their due respect, because sometimes when they come with all kinds of defenses because they don't know how you perceive them and the way they're being treated at home. And sometimes it's not that they're highly motivated, they just come on they have to come under a lot of persuasion and cajoling before they get to that point. Very few of them will come. So what do? You must affirm them, have to empathize with them, you have to respect them, and it incorporates the stages of change model. You want to know what stage the client is using the stages of change model. You should be able to assess as you speak or interview the client, you'll be able to know what stage of change the client is, so that you'll be able to move him from one stage to the other. And then it includes feedback and advice, as we shall get to know shortly. So it's not something that one does in a hurry. You must be patient and you must spare time for the client and explain everything to them very clearly, and then elicit their own cooperation so that you can do the assessment and together. Brief intervention focuses on increasing a person's insight into the awareness of substance use and behavioral change. Sometimes they just take it and as far as they're concerned, it doesn't hurt them in any way. They don't have problems with what they're using. It's just that maybe someone has observed, or maybe if you are in my own environment, the caregiver or the guardian, the parents are not happy, and they insist that they go, for treatment, and then they come. But some of them are actually highly motivated, and they know that something is happening to them, so they come. So you have to be able to increase the insight into an awareness of substance use and behavioral change, and can be provided through a single session or multiple sessions of motivational interventions by ACD or other professional or peer staff. So it's something that can be done once, or it can be done in series of sessions, but it can be done by ACD professionals. It can be done by recovery clients who are trained to do that. It can be done by counselors. You must not be medically trained, whatever, to be able to use the assist, and they do brief intervention. Whoever is interested and is educated enough can be trained to administer the assist and do brief intervention. So it is a tool that is cheap, it's easy to administer, and it's actually very interesting. But the administration or the assist is based on research work. It's not just administering it for the sake of administration. So effective brief interventions, what does it entail? Immediacy. Engage the clients early. Don't keep them waiting. Don't prolong the waiting time. If they are able to come to your own treatment facility, please minimize the waiting time and engage them as soon as you possibly can, so that they'll be encouraged, because they can easily get discouraged. As I said, most of them come, like in my own place, they're not really motivated as such. So you have to do all this, motivate them, affirm them, encourage them, to engage in treatment. So if you delay or if you waste their time in court, then you will not get them. In fact, you lose them. If referred by a healthcare worker, get the worker's support. Why? Because they may have an established relationship with the client. Those who refer the clients might have established relationship, and that is why the client in the first instance agreed to come, for this further assessment or professional care. They may have already warned the client about the dangers of substance use. So you also have to contact them and try to establish a relationship with them, so that you work together, for the benefit of the client. And client may be seeing a healthcare worker frequently. So you need to be able to compare notes, and they may also want to know what is happening to the client they refer to you. And with all permission, you can give them, a feedback about what is happening, and to assure them that the client is receiving the needed care. And clients may view the healthcare worker as being credible. So if the relationship is already established and the client views the healthcare worker as credible, then you leverage on that, and that will actually help to keep the client in treatment. If self-referred, establish trust, build a rapport and a healing relationship with the client, and reassure them, affirm them for, coming to seek treatment or advice, whatever information, whatever it is. And from there, you can pick up from there and let them feel that they are welcome. Treat them with respect and the dignity they deserve, so that they can engage in treatment. And as I said earlier, you don't rush. You must spend the time and engage them as early or as soon as you possibly can. What is rationale for screening and brief intervention? Substance use problems are widespread worldwide. There's no country that is spared. And substance use problems are associated with significant morbidity and mortality. In my own environment, since alcohol is the #1 problem where I practice, we have a lot of morbidity and mortality from alcohol-related, disorders. So it's something that you have to take seriously. And the early intervention and identification and intervention can result in a connection of substance use to health issues. We let them know that their substance use also has relationship with their health status. It's connected to their overall well-being and health. So it's not independent of their health. And identification of problematic substance use, helps so that you can nip every problem in the bud before it gets bad or before they graduate from, things like harmful use to addiction. And reduction of substance use, you can help them, at this stage to reduce it, and admission, to treatment, so that you save them from getting some complications resulting from their substances. Because by the time they get addicted, for most of them, especially those who are already in the middle ages, and in this part of the world where we practice, you find a lot of comorbid disorders. Some of them will come with mental health issues. Some of them will come with physical, medical problems like hypertension, diabetes, so on and so forth. So we need to let them know that their substance use problems can worsen the problem, and it's not independent of their physical health. There are 5 components of effective brief intervention. And first one is you introduce the issue in the context of the client's health. As I said, they are not mutually exclusive, so that they know that whatever they are doing or their choices in life is related to their health issue. And that's why you are doing this, and that's why they have been referred, and they need to see it and take it as seriously as they take their medical problems. And then screening and assessing. You screen, and for the screening, you will know whether there's need for further assessment depending on the risk. And that helps because you don't want to miss that opportunity to do that for the clients. And then provide a feedback, to them with their own kind permission and cooperation. You give them a feedback about the test you've carried out, so that they can make informed choices, and you can use that to motivate them, to get or to engage in treatment. And talk about change and setting goals. Most times, when you talk about change and setting goals, in fact, nobody engages them apart from the counselors or the substance use disorder professionals, because people stigmatize them and they see them as people who are wayward in court, and they see them as deviants, and so on and so forth. And nobody sees them down. In fact, some parents will say he's just a good for nothing. And the kind of words they use about their wards or the children is something that can discourage them. But you have to help them out and support them so that they can engage in treatment. And when you attempt to also help them to set goals, in fact, sometimes you find that they become enthusiastic about it because somebody is empathic here, somebody is giving them a listening ear, somebody is meeting them at their own level, and they are willing to do it. And then summarize and reach closure. You have to summarize, because sometimes they have a lot of cognitive problems. They might forget, they might come with a lot of apprehension, and then may not recall all that they have done. It is always good to summarize what you've done and reach closure. It helps them at least to have a take-off point, whatever will help them, to act on. Assist. Effective screening tool used in conjunction with a brief intervention. And one is substantiate that there is a reason for concern. Yes. If there is mild risk, well, there might not be reason for concern. You can just give the person information and then affirm them, and make sure that they don't progress to moderate risk or severe risk, and or high risk. And then provide opportunity for education, because out there they may not get the educational resource or the information they need from professionals like you. So it's an opportunity to actually give them some education and also intervene early before it gets chronic, before it gets to addiction, which becomes chronic and they live with it all through their lives. So you want to use the opportunity to intervene. And then at last, risk for interactions with medication. Sometimes they might even have some medical problems, and yet they are using substances. And because of their level of knowledge, they might not know that there are a lot of interaction, with even the medicines that they take. So you have to actually warn them. And some of them, in fact, are five patients, some of them who even have seizure disorders, and they are drinking heavily, and they are also taking anti-epilepsy drugs, and so on and so forth. So you need to tell them the kind of interaction, that they may have from such, and identifies the need for further evaluation. Yes, and it's interesting when you give them feedback from the assist and tell them that this is based on research, and from this score, this is what it means. And you have moderate risk or you have high risk, and you will require further assessment. And if it's moderate risk, we try to intervene and say that you want to get them to a place where they have low risk, and this is based on research. So when you give them the feedback, they are happy at least to get something that is based on evidence, and they can go with, and think about it. And whatever consent they give is out of, is an informed consent, not out of their own ignorance. And then proven to be beneficial in reducing high-risk activities. Truly speaking, if you are used to doing brief intervention and you get clients who are just low risk or moderate risk, and you do brief intervention, you find that you'll be able to help. And research has shown that it helps in reducing high-risk activities because they are willing to get information from the experts or from the professionals, and that helps them to make informed choices. International study, benefits of screening and brief intervention. Are there benefits? Sure, there are benefits. Assist follow-up scores significantly lower than baseline scores. When you see, for instance, they come to you for the first time, and then you are able to engage them, and in the treatment process, you're able to administer the assist, and then you score them, and with their permission, you give them the feedback. Maybe after 6 months, they come again, and then you're able to administer the assist again. Discover that the scores are likely to be lower, and you may be able to move them from moderate risk to low risk. So it works. And brief intervention was effective compared with no intervention in reducing substance use and risk. Several studies have proven that. And brief intervention influenced cutting down, stopping use, thinking about stopping, and feeling better because they've gotten information from the professionals. And study results supported earlier studies that found brief interventions to be cost effective. In fact, it is cheaper, it is easy to use, and very convenient. You can do it in one sitting, you can do it in several sessions, and it doesn't really cost anything. Everyone who is interested, who is educated enough, can be trained. Even peers, those who are recovering, can be trained to administer it, and they do it well. So opportunity to generate change talk with the assist appear to play a significant role in influencing behavior change. Yes, when you understand the assist and they are able to give the feedback and then engage them now, in talk, try to motivate them, create discrepancies. That helps them to actually change and engage in treatment. How is assist linked to brief intervention? How is assist linked brief intervention conducted? Yes, as you said, you don't just do brief intervention for the blues. You must have administered the assist, then you would have scored and discovered that there's moderate or high risk before you engage. So you have a basis for doing brief intervention based on your scores. And by so doing, you would have elicited the cooperation of the client. You would have been able to establish some rapport and some, and some form of alliance with the client, to continue to the level of brief intervention. And they are happy because it's based on some results. Sometimes they do it out of ignorance, but when they get this information from you, they are able to adjust and change for the better. So for clients who have been administered the assist, yes, short intervention in 3 to 15 minutes. 3 to 15 minutes is enough for you to do brief intervention, depending on the time, at your hand. And then give a personalized feedback. It's not the same score for everyone. So you tailor it to the score and to meet the needs of the client. So it's personalized, and sharing assist risk scores with the client to get to know why you are doing the brief intervention and why you think the client needs the brief intervention. And then it's non-confrontational, because if you start confronting them at this stage, they will raise their defenses and you may lose them. They may drop out. And successful mostly with moderate risk clients, yes. Because the high risk ones will need further assessment and more professional treatment. Then some comorbidities and some other complications would have set in, maybe because of the addiction.
Moses, there's a question that I think is worth interrupting to ask.
Okay.
The question is, so brief intervention should be done after the assist. When does one do motivational interviewing?
Pardon? It should be done, yes, it should be done.
Yeah.
It should be done after the assist, yeah.
So then the question is, when do you do motivational interviewing?
Motivational interviewing? Yeah, in fact, the motivational interviewing can even begin before you even administer the assist. It can be done while you are administering the assist. It can be done after the assist, after even brief intervention, when you are even doing further assessments. It can be done when you are actually starting some treatment of your admitted. So the motivational interviewing, to motivate the client to get to a point that we want to, take the assist. So the motivational interviewing spans all through. From the first time you meet the client, you can continue till the time maybe you discharge, and then it continues, as an outpatient and comes. And each time keep motivating them to remain, at the level of abstinence. So motivational interviewing has no specific time. It spans all through. You employ it each time you think is necessary. I don't know whether I've answered the question, but for brief intervention, you are trying to use it based on your assessment or based on your score and the assist. This is the basis for which I'm giving you brief intervention, because you have moderate risk. You even have high risk. And I want to give you brief intervention before I refer you for further assessments. So there will be a basis for it. And that gets them, you're able to elicit their cooperation that, look, from the assessment, you have a moderate risk and you need this intervention. Or you have a high risk and brief intervention is just the beginning. You will need further assessment so that you can get more, expert care or professional care. I hope I've answered the question. Hello?
I think you have, so hopefully the person who asked as well thinks you did.
Well, okay.
He said yes.
Pardon?
He said yes.
Okay, thank you very much. So it's successful mostly with moderate risk clients, as I said, because at that level, they have not gotten to the stage of dependence. When dependence comes, it's much more difficult. Brief intervention alone will not be enough. You will need further assessment and then engage the person in treatment. Then other co-occurring disorder would have set in, and other complications, would have also set in. So brief intervention will not be enough for those who have high risk. How is the assist-linked brief intervention conducted? Yes. Asking clients whether they are interested in seeing their assist course. For instance, we administered it to our honorable clients, George, last time. So we now affirm him and thank him for taking the test and tell him, okay, we have done we have administered the assist, we have scored, and we kindly ask him whether he's interested in seeing the assist course. Since he was patient enough to take it, is he interested? Will he be willing to get the score so that we can discuss his score with him? So it's very important. Providing personalized feedback using the assist feedback report card. You know, Beatrice, showed us the report card last time. So you now use that to show them or to show the client his personalized score or the report card. And we are able to say for George that he had high risk for tobacco. We also thought of alcoholic beverages, but just moderate for cannabis and sedatives, you know. So you now, for individual substances, you know, for every substance, we give them their personalized score and tell them, you know, the risk, whether it is low, moderate, or high, and then giving advice about how to reduce risk associated with substance use. Here, based on your experience and then the score, you can give some advice that will help the client, tell them about what others have done and how it has helped them, but you do that respectfully, you know, so that so that they will have, you know, the choice whether to go with you or not, but you don't impose it on them. And allowing clients to take ultimate responsibility for their choices. That's why you give them this feedback, you inform them, you educate them, you affirm them, you know, you encourage them and do everything so that they can, you know, take ultimate responsibility for their choices, because then you can hold them accountable, you can keep reminding them of the choices they have made and encourage and support them, and then try to create discrepancy between the choices, you know, they have made and where they are going ultimately, so that they can move, you know, in the right direction of change you desire. Asking clients how concerned they are about their scores. Yes, you have to ask. We ask George how concerned he is about his score, particularly for tobacco and alcoholic beverages. So we need to know whether he's concerned. We don't say, "Are you not concerned?" No. How concerned? You see, you have to use open-ended questions so that you respect them, and the choice is ultimately their responsibility, or the onus is on them to make the choice. So how concerned, because that will help them to know that yes, they also have some control over the session, and that they are being respected, so that they can make, you know, the choices they want. The next 5 steps in conducting an assist-linked brief intervention. Number 6 is weighing the good things about using substance. You cannot tell them that there's nothing good in using substance. If you tell them, they will not take it. You know, for my client, I say, I know these substances, maybe you derive some benefit from using substances, no doubt. If I say you don't derive benefits, then I'll be telling a lie. I will not be a professional. Then they will know their head, yes, truly so. There are benefits. So weigh the good things about using substance, and then weigh the less good things about using substance. You know, Beatrice, you know, reminded you don't say the bad things about using substance. No, you now become judgmental. You don't say the bad things, the less good things about using substance. So George will tell us what the good things about to weigh whatever benefits derived from using tobacco and cannabis, sedatives, and alcoholic beverages. So he would now tell us, okay, these are the benefits I derive and why I have been using them all along. Then, when the less good things about using substance, this is where you begin to say the time, the energy, the cost, you know, and then how it has cost him not only in monetary terms but relationships, and then maybe his performance at work or at school, so on and so forth. So when the less good things about using substance, and encourage him to bring them up, and then you weigh them, but you try to balance it in favor of change, so that he can create discrepancy, you know, so that he can move, you know, towards the next stage of change. And then summarizing and reflecting on clients' emphasis on less good things. Yes, you have to summarize and reflecting so that you now stress it again. It's coming from you, the less good things. These less good things might not help you to achieve your goal or your ambition in life. So that he hears it from you again. He said it, but you are repeating it so that he keeps remembering that yes, I said this myself, and he can now take the responsibility, to towards changing. And then asking clients how concerned they are about less good things. How concerned are you really about the less good things? Are they really concerned, or they are just, oh, well, there's nothing wrong in it? So you have to know, let it come from them. You are not imposing on them, because they need to also feel that they are also part of the session, and they have some control. It's not a master servant kind of a thing. When you do that, you find that you're able to build rapport because you respect them, and they feel they are dignified. You are not seeing them as people who who are maybe deviant as society sees them. No. So that helps them. And then giving clients take-home materials, because you must have some information about the substances that are of abuse in your own locality. They will need some maybe material, then you give them the one that will help them so that they get more information, and maybe they can read, and if they are coming next time, they can go and study such materials and then come back and you discuss with the clients. And they're happy going with that. First off, I would say, can I take more for my friends? I said, please go ahead. So steps 1 and 2, ask and give feedback. So start the conversation by asking if they want to see the result of their assist. Yes. Start by asking them if they want, not say, okay, this is your score. You did this, oh, you have very high risk, too bad. No. Give them their due respect. Ask them if they're interested. Use the report card to provide feedback to the client. Record the report card that Beatrice, showed us last time. So I'd like to share with you the results of the questionnaire you just completed. These are your scores for each substance that we talked about. You scored a 14 for alcohol, which puts you in the moderate risk group for that substance. You scored in the low risk group for all other substances. This is just an example. So we used George last time, the scores. So you now start that way. The best way, offer advice, the best way to reduce your risk of alcohol-related harm is to cut back on your use. That is to move from this moderate risk category, point to the podcast. They have to point so that it sticks. You have already a moderate risk. So I want you to move from this back to low risk category. I point it to the card so that they see it, to know that that affirms that yes, they had actually taken the assist, and then you have scored them, and it's based on that you are doing this. It's not just coming something offered, no. And this is scientific. Research has been done on it and found to be effective, and that's why you are doing this. Steps 4 and 5. Place the responsibility on the client and elicit client concern. Yes. What you do with the information is up to you, entirely up to you. I'm here to assist you if you would like cutting back on your use. At that moment, they will say, yeah, I want help, that's why I'm here. So what are your thoughts about your scores, particularly the one for alcohol, moderate risk? So if it's for John, will say he had high risk. So this is it, and he will need referral. So take note and reflect back clients' change talk. When they talk, you have to listen actively. Here you use open-ended questions, remember, not closed-ended questions, and then you listen to the change talk. It's the change talk that you cash in on that, and try to create discrepancy, affirm them for the change talk that they have actually made. They will make the statement, so you listen to it, always look out for the change talk, and then create discrepancy so that you can advance them from one stage of change to the other. That is the essence. But if you don't, you will miss it. Step 6 and 7, encourage clients to weigh the benefits and costs. What are some good things about using alcohol for you personally? Yeah, they tell you. What are some of the not so good things? Not be judgmental. The bad things about using alcohol, no. Because people in my own environment, that's what people will say, the bad things about using alcohol. You know they are not supposed to be taking it. And you know that you are not a serious person. No. What are some of your concerns about these not so good things? So you are empowering them. so that they can talk and they know that they have a say in it. You are not just pushing down everything to them and imposing things on them. No, but you are eliciting their own cooperation so that you carry them along, so that they know that the responsibility is on them and you are just coming alongside them to help them, towards this journey to change and then to maintain a recovery. Step A, summarize and reflect on the not so good things. Okay, for instance, okay, so on the one hand, you have mentioned a lot of good things about getting drunk. You have a great time at parties. You are not so inhibited around your friends. Everyone thinks you are the life of the party. Wonderful. But on the other hand, you have missed a lot of class time. Your grades are suffering, and school is very important to you. So summarize. You can see you've summarized it, and you've developed, a discrepancy here. Yes, a lot of good things you're dealing with the party, but on the other hand, you have missed a lot of class. So how will you now make up for this? Will this behavior help you to make better grades, or is school no longer important to you? You've already said that it's very important. So that will help them to think, because you already tried to create discrepancy. They know, oh, truly, if I continue this behavior, I'm not gonna make progress in my academic work. So then the change talk will come from them. Then you catch it on that. Step 9, ask how concerned client is about not so good things. Okay, ask open-ended questions, of course. And the follow-up on discrepancies developed in step 8. Because you have tried to summarize and then create discrepancy. Then they may say, okay, truly, yeah, these things, if I continue like this, my grade will suffer and I will not be able to make good grades at school. I think I need to change. Thank you very much. You need to change. So how are you going to do it? It's not, you must change. Definitely you must change. No. How are you going to do it? Then pick up that. Do the things we just talked about, missing classes and getting poor grades, concern you? Tell me how. So, or it's not, you should be concerned because your grades are bad. If you have their, in my own experience, if you have their guidance or their parents, they say, he has to change, doctor. He has to change. The grades are bad. He has to change. No, sometimes I say, excuse me, can you excuse us? Let me talk to him. Then you can come later, because sometimes they discourage and then they frustrate the client, and they are also displacing their own frustrations, about their own word, in the setting. So you try to do that, and then help them to know that it's something that they should be concerned about, but let it come from them, and then they tell you how concerned and what they think they want to do. Provide take-home materials. Assist feedback report card is very good. The score is there. Reminds them that they have moderate or even high risk. General information pamphlets on the substance being used. You should have them in your treatment setting so that when clients request for them, you give them. Here we have some, and then the UTC provides with a lot of materials on various substances. So it's easier to go to the information shelf there and rack, and then they pick one, or you pick and give them. And self-help strategies for cutting down or stopping substances you can help. And then if they have been injecting, you also go to the, you call the card for the risk of injecting. So that also you give them, and then you go through it and see, the risk they have for injecting substances, if it's relevant. Making referral for further assessment and treatment. Giving a phone number is not enough. It is very true. Even from our experience here, it's not enough. If you have to make referral, what we do, in fact, is either the case manager or sometimes one of our nurses in the treatment center, goes with the referral with the client. They go together and then they sort out everything. They wait for them until they get a booking. And if they have to see maybe a professional or maybe a physician or a surgeon outside, the treatment center, they go with them until the procedure is complete, then they bring them back. And that really helps them. Sometimes they are diagnosed with HIV, almost, HIV, and then they have a lot of symptoms, almost going to AIDS. And for the first time, they're getting to know that they're HIV positive. So what do? Will you just refer them and say, go? No. It's, because the stigma, what we do, the case manager or the nurse, goes with them, and they're happy that you accompany them in this journey. You go and book for them, and they sit there with them, when they're through with the session, they bring them back and they feel somebody is alongside them, helping them, and that has actually helped them, to remain in treatment. So take a proactive role in learning about the availability of appointments or treatment slots, costs, and transportation. We do that, and before we refer them, and then we take them there. And then get names of contact persons at each program. We do that for them, and also until they leave the facility. And that really helps them so they don't really have drop out from the treatment. It's very important because of the stigma and the way society looks at them, and the judgmental attitude, towards them. It's difficult for them, to go there on their own. But when you accompany them and you sort artists for them, they are really very happy. Making referrals, confidentiality. Be aware of laws and regulations about communicating patient information. Yes, if you are going to make referral to the, you also let the client know that if he's going, the professional or whoever is going to take over might need some information from him to help him to be able to assess him, diagnose the problem, and treat. So will he be willing that you share some information? If they say yes, go ahead. And usually when you are there with them, they don't want to hide it. They say, please go ahead, whatever will help me, since you're there with me, I'm okay. So get written consent from patients and be aware of laws regarding minors. Yes, because minors, well, by our laws, it says anybody less than 18 years of age is arbitrary, is a minor. So you might have to take responsibility for them and help them if they are minors. Or sometimes their parents come in or their guidance and say, look, okay, at this point, I want to take over, but you are there alongside them to help them. That's what we do in our own environment. So encourage follow-up visits. Inquire about use, review goals and progress when they come for follow-up. If they are not using or their scores in assist, is low, you affirm them and and then reinforce and motivate them. Review tips for progress, and if you do that, they know that you are actually there for them, and it helps them, to move on. So here we have a group exercise. We have done the scoring together. The rest you will be able to do them on your as an assignment. So we're not going to do this now because time is not on our side. And then reflective exercise, summarizing the effective use of the assist in brief intervention. What are some of the advantages of an assist linked brief intervention? Then how does a brief intervention differ for clients who are deemed moderate risk versus those deemed to be high risk? So this, you reflect on it. We have done with the scoring together. Beatrice was there, we did the scoring, and then we used Honorable Judge as the client here, and then we scored. So from what you have learned so far, think about it and reflect. How does a brief intervention differ for clients who are deemed moderate risk versus those deemed to be high risk? What are the 10 steps followed in an assist-linked brief intervention? What take-home materials would you want to have available at your treatment program as a means of bolstering a brief intervention? So these are things you reflect on, and you'll be able to carry on your center. So we are through with this. We'll go to the next one, so that it's short. So we'll be able to do that. And
can someone ask a question?
No, let's finish. You can ask the question, please, so that we don't encroach on Beatrice's time. You can ask me a chat. I should be able to finish so that you ask 1 or 2 questions. So please hold on. Thank you very much.
Thank you.
Assessment. Yes, thank you. Module 4. We're now talking about assessment. Before then, what are the goals of Module 4? Is to provide an overview of the principles of what assessment is all about, and to give counselors an introduction to the domains of assessment in substance use disorder treatment.
Moses, we can't see your slides
Module
yet.
4, these are the learning objectives. Describe the process of assessment and list the 4 main domains of assessment. Let's go on.
Moses, we can't see the slides.
Oh, you can't see the slides?
No.
Oh, sorry about that. Can you see now?
No.
No.
Oh, okay, okay. I'll go back again. Sorry.
Okay.
Okay. So we are now on assessment. As I said, the goals, I'll go quickly, is to provide an overview of the principles of assessment. And then the second one is to give counselors an introduction to the domains of assessment in substance use disorder treatment. So these are the learning objectives. Describe the process of assessment and list the 4 main domains of assessment. So by the time we complete this module, you'll be able to describe these principles of assessment and also list the 4 main domains. So please, can anyone tell us what are the domains that you assess a client? If a client with an ACD come, what do you think are the domains that you actually ask or you assess the client on? I want maybe one person to tell us what to look for. What areas will you be looking for? Anyone can answer, please. Aki, please help me.
Yes, one area that is important is the cognitive domain.
Okay, what else?
Tima has her hand up.
Okay, please, go ahead.
Yes, we can look at the health of the client.
Very good, thank you very much. Any other?
You can consider the behavior of the client too.
Thank you very much. Any other?
History of substance use.
Okay, thank you. Let's go on.
History of substance use.
Yes, very important. So this is a personal view now. What do you find most rewarding about your job as a counselor? Can anyone tell me just one? What do you find most rewarding about your job as a counselor? Please, I want an answer from somebody.
Yeah, can I say?
Yes, please. Go ahead, please.
Yeah, bringing happiness to the life of others, giving meaning to life.
Thank you, Prof. Thank you for this active participation. That's a great one. Any other person?
Being able to stay hope in a client.
Thank you very much. Thank you. Any other person?
Yes, several.
One more.
Can I go on?
Yeah.
Okay, they're being able to help people to overcome their life challenges.
Thank you very much. That's very interesting. So, counselor's role as a guide. You ask about what the client's goals are. Ask about what assistance or support the client wants. Respectfully offer information. Don't impose. Partner with the client to assess the information, skills, and resources, the strength, the recovery capital, and all that they need, for the treatment. Then assessment. What is it? An in-depth gathering of data and information, typically conducted at the initiation of treatment, needed to understand an individual's or family's needs as a prerequisite for developing a plan of care. So you can see you conduct a lot of information, and it's not just on one-off thing and not from one source. The purpose of assessment is to understand the nature and causes of the individual's particular situation and to consider possible routes to recovery. Yes, different routes, and then you encourage them to, because you need to empower them to choose, to make informed choices, and the responsibility is on them. You only come alongside to guide and to assist them. And then it's an ongoing process of collaboration. You cannot do assessment at one sitting, everything you need, no. They will continue to reveal many things to you as time goes on, and as you establish rapport, and then there's therapeutic alliance, and there's that trusting relationship, then you get to know more. Assessment, initiation of building a trusting relationship. It starts from there. So the first encounter matters. You must support, you must affirm the client for coming. You should be able to use your motivational skills here, interview skills, to help them. And it also helps to develop that therapeutic alliance with the client. If you miss it here, you will not be able to help the client. They may drop out, or you may not get or fully assess them. And assessment is like the story they said of an elephant where you have 6 blind men, and they ask them, okay, one of them to touch the elephant and to describe what the elephant is all about. One touched the legs and said the elephant is like a tree. The other touched the tail and said the elephant is like a rope. One touched the trunk and said the elephant is like a snake. The other touched the air and said it's like a hand fan. Another touched the belly of the elephant and said, oh, the elephant is like a wall. One touched the task and say the elephant is like a spear. So who among them is correct? Your guess is as good as mine. So assessment has different dimensions. You have to look at the patient in total. It's not just taking looking at one dimension. No, it's everything about the client that you need to know to help them, to stay in recovery, and all their resources, the strength, the recovery competence they need to make progress. Now, select for assessment competencies. I remember, I recall Morakwe talked about tab 21 for us. If you have gone through it, you will know. Select a process that is sensitive to gender, race, ethnic, culture, and disability. For those of us who practice here, it's not easy for the counselor, because there are a lot of cultural sentiments, religious sentiments that you have to negotiate to be able to keep the client in treatment. And then for the fact that they pay out of pocket, no insurance for it, and it's their parents or their guardians that pay, or some of them who are working may be able to pay. So you have to strike to a balance. It's working a tightrope, and you have to be sensitive to all this, the race, the ethnic culture, and then the disabilities. Analyze and interpret the data to determine treatment recommendations that you give, and seek appropriate supervision and consultation. Yes, if you need help, seek supervision and consult your other colleagues or senior ones. And then document assessment findings and recommendations. You have to document them. Everything you do, document it. If you have not documented, you've done nothing. You have not done anything. So document every assessment findings and recommendation is good for reference, and especially when for forensic purposes, there are times that they will make reference to your documentation. So always make sure you document everything you do. And what is the purpose? Identify substance abuse pattern and history. You need to know the pattern of use. You need to know the history, social and psychological functioning of the client, and general treatment needs. If you don't assess and get all the dimensions, you cannot get all this. And you cannot get it at a sitting. So you need to consult and then initiate treatment process. The treatment process will only be initiated when you have gotten good assessment and with the cooperation of the client. Determine the extent and severity of alcohol and other drug abuse problem. What is the extent? If you screen, it will tell you whether it's a severe, high risk or moderate. Then you get to know, and you know what step to take, whether to refer or do brief intervention and further assessment. Determine the client's level of maturation and readiness for treatment. Stage of change is important. And ascertain concomitant problems such as mental illness or even physical illnesses. And majority of our clients will come with co-occurring disorders. So see one, look for the other. What's the purpose? Continue. Determine the type of intervention that will be necessary to address the problems. It's based on your information, your assessment, that you determine what is best for the client, because there's no one should fit all. No, you must tailor it to the needs of the client. Then evaluate the resources the client can master to help solve the problem. The strengths, what are the capital, the strengths, all the other resources, and the recovery capital that the client has. And then engage the client in the treatment process. Very key. Screening versus assessment. Screening is a process for evaluating the possible presence of a particular problem. So what is assessment? Assessment is a process of defining the nature of the problem determining a diagnosis, and developing a specific treatment recommendation for addressing the problem or diagnosis. So assessment is more comprehensive, is more in-depth, is more time-consuming, I know, because you really want to come up with a diagnosis. You have to plan for treatment. You have to look at what treatment actually suits the client, and you want to make recommendations for addressing the problems, looking at the resources available and the recovery capital, so on and so forth. So this is what you do. Small group exercise, that will be done by BTs. Know that? No. And the forward information you really need to know in your first session. So, okay, sorry. Separate the information into categories. If the reason to stop or cut down use of substances, write down one category per post, it not occur 10 minutes. So you can do this, but that's not now, later on, as assignment. The nature and severity of problem use and problem. Quantify the frequency and pattern of substance use. What have you been using? How much, and how negative consequences, and the substance dependence.
Moses?
Yes, I've entered on. Yeah.
No problem. You can rest now.
Rest. Thank you.
Yes, you can rest, and then I can share my screen. Thank you very much.
Thank you. But I think they have a minute or two to ask their question before you take over, please.
Or maybe they can ask at the end, because we also have some that they have typed in the chat. We can answer them in the LMS or at the end if we have a few minutes.
Oh, okay.
Is that okay?
The question is related to her presentation. Can I just ask briefly?
Okay, go ahead and ask. Moses will respond as I share my screen.
Yes, please. The question is on the results of the assist, and you said that if the score is significantly low, that is a cause for concern. If it's low beyond the baseline.
If the score in the assist?
Yes, the score in the assist. I saw it one of the statements, one of the slides.
If it is low risk, low or no risk.
No, the slide says if the score is below the baseline for no risk. So that there's concern to probe, something like that. So I wanted to see whether I can have more explanation what to do in that situation, because we didn't have that explanation yesterday, the other day when we did the assist scoring.
Okay, the scoring.
Yes, when we did scoring of the assist with George, when George was the client.
Yes.
What we found out was moderate risk, but we didn't have the situation where, which that slide showed, that there was somebody's score was below baseline, and that should be a source of concern. So that I wanted to see whether we can share more information about what nature of concern we inquire in a situation like that.
Yes, I know. I still have the scores here with me, because it was for opioid that the score was 2, which was like low risk. So that you only need to give information and affirm the person. You don't need, for opioid, you don't need brief intervention. But you can probe further, because sometimes they may be economical with the, with their facts if they are not sure, or maybe they think you are a little bit judgmental, or they want to hide the result from maybe whoever is sponsoring that treatment. But with time, you can still probe further if you think there's something not right there. You can still probe, and then as you establish rapport and trust, and confidence, they will begin to tell you more things that they didn't tell you. In fact, they may tell that information I gave you last time, truly speaking, wasn't right. I was afraid that you are going to condemn me or judge me, but since I see you as somebody who's really willing to help, I use more than that. This is what I do. So there are times that if you suspect, based on your experience, you can probe for them, but not at that time. Don't confront them at that time, because they can shut up, and then they can drop out of treatment. But if it's low risk, because the scores are there expressly, whichever this range to that range is low, so and so is medium, and this one so is a high risk. So you can do that. I don't know. Maybe Beatrice, take over, please.
Maybe bosses, because you have one more minute, you can answer the question that was asked by someone as well.
Okay. I thought
On-
you wanted to tell me.
Can I ask a question?
Okay, please, can I hear the question, please?
Yeah,
Yeah,
the question was that what do you do if the client says they do not want to receive their assist scorecard? The
Yes.
report.
Yes, you don't force them to receive it, but you can. This is where your motivational interview skills come into play, and you can also book another appointment to meet them. Just use your motivational interview skills and talk to them. By the time they come, you can book an appointment with them. They come later. I tell you, they will open up. I've seen clients who come that way. They don't want anything, any result, whatever. But as you keep talking to them and then creating discrepancy, and then you find that, okay, can we have another appointment at your own convenience, earliest convenience? They say, okay, I'll be able to make it next week. When they come, they would have thought about it. Next time they open and say, okay, I want to see the results. So you don't just give up, but don't confront them.
Dr. Oko was unmuted wanting to ask a question.
We can continue on the elements. Yeah, we can continue on the elements. So, Beatrice,
Okay.
please go ahead.
Okay, thank you very much, class, and we appreciate your participation. We shall continue with more engagement in the learning management system so that we can answer more of these questions and also exchange our perspectives. I think that one of the participants' question, he was talking about baseline. I don't know whether there's a slide where it says if your scores of the client in follow-up assist administration differ from the baseline, then you need to engage more, because maybe at baseline, the client may not have given the information in an honest way. So you need to validate that. So there is that slide. So maybe that's also what he's talking about.
Yes,
so next class, we are going to be looking at, like Moses has introduced, assessment. And in the next few slides, we are going to be talking about the domains that we need to focus on when we assess our clients. Let's remember, and I do like the references that Moses was making in his presentation. He was reminding us that our client George was using 5 substances, or had used 5 substances. He had a low risk for one substance, that was the opioids. He had a moderate risk for cannabis and sedatives, and he had a high risk for tobacco and alcohol that then requires more intensive intervention, including referral for assessment. And so the question is, if we send our client George for assessment or refer him for assessment, what are the things that we need to think about when we conduct assessment? While we are going to be looking at one of the assessment tools called Addiction Severity Index, it's good to note that it is not a must that we use ASI. You might find that the logistics in your setting do not allow. However, whatever method of assessment you use, there are certain domains you must take care of. And that's what this next presentation is going to be talking about. And these domains are covered in ASI plus many others. So the first domain is finding out the nature and severity of the substance use and the problems. Now, when we think about the nature, when we think about severity, what are some of the things we want to consider? We want to think about the quantity of the substance that the client is using. We want to ask about the frequency of use. Are they using daily? Are they using 3 times a week? Are they using weekly? And remember, some of the questions we asked in Assist are actually related to this. What pattern of use are they having? You ask them what they've been using. You want to know how much. You want to know the methods even of administration. Are they using it as, and you remember the different routes of administration we covered in UTC 1. Is it oral? Is it inhaling? Is it snorting? Are they injecting? All these are important questions to ask. And we ask this about each of the substances that the client is using. We also need to ask about the negative consequences of the substance. Of course, I like the MI approach, which asks about the not so good things. So these are the things we want to pick. What are the not so good things that this substance has, caused in the client's life? We also want to assess whether there is substance dependence, and we're going to be talking a little more about this in the next slides. So in the negative consequences, again, we want to pick some of these areas. And have there been consequences affecting the family? Sometimes the client may not even think about it that way, but the client will tell you that my wife is always making noise about my substance use. So you know that is a problem. It's a negative consequence in the area of family. Sometimes they'll tell you that they no longer have time to meet their friends or to go to their religious places like they used to. This is social relationships. Sometimes they'll tell you about their boss. They'll tell you that they've been given a warning at the office. Sometimes it's about missing school or missing assignments, to complete assignments. Sometimes it's their mood, finances, legal problems, or health problems. So it's important that sometimes when we ask the client whether they've had negative consequences, they may not necessarily remember, but we can prompt them using these different areas. Now, further negative consequences which are related to health, we can ask them whether they've had some physical harm because of their substance use. I have seen a lot of times clients who have been using alcohol tend to have all these marks and injuries. Sometimes they have lost teeth. Sometimes they have fractures or scars. Sometimes you inquire about them and the client opens up and tells you, yeah, this I caused an accident while I was drunk, and so I lost my teeth. So all these things, we look for them, the medical conditions, the cognitive impairment someone talked about. And let's remember that sometimes the client may not even remember or connect these things with substance use until you prompt them. And these are some of the things that are going to be the basis of our motivational interviewing when we begin to talk about the not so good things that Moses was talking about. Now, in terms of cognitive impairment, it's good to remember some of the substances have got temporary effects of cognitive impairment. For example, alcohol may impair memory, may impair attention, may impair learning abilities, and even sedatives, amongst other things. But there's also the long-term impact of some of these substances on the cognitive impairment, which may not necessarily be reversible. So ask about this. Now, issues about physical substance dependence. Remember, we talk about physical adaptation. We also talk about the psychological dependence. So in the physical dependence, we are looking for tolerance. You remember we were told in UTC 1 that tolerance is about the client needing to use more of the substance, whether it is in higher doses, whether it is in a quantity, to achieve the original, the original feeling they were looking for. You remember physiological dependence has to do with the withdrawal. And so we want to remind, in our questions to the client, we want to assess whether there may be probability of withdrawal. So ask the client the types and amount of substances they've been using, whether they have any history of withdrawal, and of course, their current psychosocial and medical needs. Now, again, some of the signs of withdrawal that require immediate attention, we need to look for them. If your client is withdrawing from alcohol and experiences delirium tremens, we know the risk that it poses. So if we don't know that, if we don't pick that early, clients have actually died in treatment settings because of this. So we are being reminded here that we need to look for these signs. The changes in mental status, sometimes we see confusion, hallucinations, seizures and fever, abdominal pain, among others. So this is asking us to remind ourselves of the various withdrawal symptoms of the different substances and be able to see the ones that can be life-threatening, so that we ask about them and take prompt care. Now, there's also the psychological dependence aspect. We need to ask the person how the substance has affected their other activities, their other relationships and social roles. Remember Moses took us in UTC 1 or Morekwe, the picture, the slide where we were seeing how the substance, as the person progresses in use, takes over all their other activities, from relationships to family activities, their work and everything else. And so we want to look at that aspect of the client. Are they spending increasing amounts of time, energy and resources, whether it's in obtaining the substance, using it or recovering from the effects of it? We also want to know whether using the substance is the only way the person can cope with certain feelings. Then we begin to understand the psychological dependence aspect of the substance. Now, we have an interesting case here of Faisal. It is in resource page 4.1. It's a case study, and you're given a whole story about Faisal, and you're going to use that, and we're going to post this in the LMS to try and look at the areas that you will be assessing Faisal about, and give an idea of what are some of the answers that he would give to each of these questions. So once we get to the LMS, let's each attempt to do this, to imagine that we are Faisal And we are responding to the questions we have been asked by the assessor around each of these areas, and we try to respond. So we'll share more about this in our LMS. Now, so that was the domain about the substance use. The second domain that we must assess, and this has been coming time and again from the presentations we've been having, is the need to assess the motivation for change. I know Moses had said in his presentation that we need to assess the motivation and readiness to enter treatment. So it's important because, and I have said this severally, that sometimes I have seen many clients in treatment who are at the lowest level of motivation for change. They've been in treatment for 3 months and they are still at the level of pre-contemplation. This is probably because someone failed to assess very early the motivation for change and identify where the client was at entry and use the relevant strategies to move the client up the stages of change. So it's important to use the MI techniques. Remember the Dan C, D for desire, A for ability, R for reasons, N for need, and C for commitment. Someone asked, when do you use MI? And Moses was right in saying we use it across the board. So as we are assessing, we want to know, does the client have desire? Do they feel like they have a reasons, need, and commitment? We need to ask open-ended questions about the importance they have of making the change for them. And you know, if you remember some of the consequences, the negative consequences, we'll point you now to some of the areas you will be asking around when you're talking about the importance of making the change. So for example, if the client said the substance has affected their academic work, you might ask them, how important is it for you to make a change in your substance use for the sake of your academics, especially if they mentioned that academics were important to them. Ask them about the confidence in the ability to make change. Remember, we did say it's possible for a client to have a deep desire to make a change, but they don't have confidence that they'll ever make it. I've had a client who'd been in rehab for 7 different times in different treatment centers. And he said, I'm not sure if I'm going to hack it this time. So you can see that client has desire, but is expressing doubt in his ability. You need to pick that so that you know where you come in. We talk about readiness for change. You can remember our readiness ruler, which we can use to assess, you know, the readiness for the client. The other third area, very important, is to do with recovery capital. I mean, I always like to remember Morekwe took us through recovery capital very well. We want to assess the client's recovery capital. What sort of strengths do they have? What sort of resources do they have? Let's remember, the recovery capital can be personal, it can be social, family or social, it can also be community, and it can even be cultural. So as we do this assessment, let's assess all those domains of recovery capital, the skills of the individual, the strengths, the resources. Let's also remind ourselves that in the personal recovery capital, and maybe I should ask you this question actually. I like to ask this question a lot. In the personal recovery capital, we have 2 types. We have got the physical and we have got the human. Can someone remind us what was the physical recovery capital of the person? And someone else can remind us what was the human recovery capital of the person. Anybody that wants to tell us that? Yes, recovery capital. Any answer, any hand that's raised? Or any communication on chat? Yes, personal recovery capital was divided into 2, physical and human. So examples of physical include, yes, Alero.
Physical included their jobs, accommodation.
Very good. So your client has a job. Thank you very much. Anybody else who wants to give an example of either physical or human recovery capital? Yes, this is so very important. We need to keep reminding ourselves. Anybody else with a guess? Yes, Alero again.
Human capital, the person's personality.
The personality of the person could also be an example. Thank you. And I can see some charts. Let's see whether there's also Kennedy. Kennedy? Yes, Kennedy, please unmute yourself.
The shelter.
Sorry? Okay, I'm sorry, Kennedy, we can't hear you. Please type in the chat so that we can hear you. You can get your response.
If the person has a shelter,
If the person has shelter, thank you very much. Shelter is a physical personal recovery capital. Thank you. Any other example of human recovery capital? Again, Kennedy wants to say something. Yes, Kennedy? Or anybody else?
You have Ujunwa.
Yes, Ujunwa?
Okay, the human recovery capital, so you would have the person's, probably the value, some of their skills, some of the experiences, so the things that actually come from the individual. Then the physical recovery capital, like they've mentioned, you know, the person's job, transportation, shelter, access to food, all those other physical things that make up, that helps the individual.
Thank you. Thank you very much. We really appreciate your contributions. Now, anybody who wants to give us an example of family and social recovery capital? Family and social recovery capital, anybody? Yes, Kennedy?
This is good for,
I
think, a supportive family.
if the person has social support, yes.
Supportive family, thank you very much. Any other? Anybody else?
You have Rania with her hand up.
Yes, Rania?
Yes, social recovery capital means if his work is enabling him to take a vacation to continue his treatment.
Thank you.
Support from his work.
Thank you. So support from his work to come and receive treatment. That's a social recovery capital. Thank you very much. What about community / cultural recovery capital? Let's hear an example of community / cultural recovery capital. Yes, Rania?
If in the neighborhood he has an AA meeting or NA meeting or a community approach recreational activities.
Thank you.
Around
Thank you very
his
much.
neighborhood.
Thank you, Rania. So if he has got some support within his community, maybe he has an AA meeting group that meets in his neighborhood or in his church or wherever, that's an important community recovery capital. And so we are saying when you're doing your assessment, assessing the client's strengths and resources is helpful because it will help you in terms of treatment planning. So explore their strengths. This can increase their self-confidence. It can also increase their motivation to change, and it can also help you as you are building the therapeutic alliance. Now, as you're assessing their strengths and their resources, you can ask them the following questions. Ask them what is most important to you. The client can give you different answers about what is important to them. And this is important because sometimes, while we think we can see the client's resources and strengths, what might be looking like a recovery capital to us may actually be a negative recovery capital to the client. So it's important for them to tell us what is most important to them. We could also ask them, what successful change have you made in the past? And the client can tell you that, you know, there's a time I actually used to use another substance and I decided I was going to quit and I was able to quit. And then you can ask them, what obstacles did you overcome to make that change, or how did you do it? And this change does not only have to be in the area of SUD, it can be just a change in any other area of their life. Because remember we said, we want to start where the client is. So if they don't think they can make a change around SUD, we can ask them whether they've ever made a change in any area of their life. And they will tell you many other areas, and you can pick on those ones to try and build their level of confidence. Now ask them, if you were to decide to make this change, how would you do it? Again, the client will tell you what they can do. Again, that helps you gauge where you think, where the client is, and that helps you know how much more you need to do with this client. Ask them who can support them in making the change. Again, this is part of the recovery capital. They may tell you someone in their family. They may tell you a distant relative. They may tell you a neighbor. They may tell you someone at the office. All this is important because that's what you're going to be drawing on as you build the recovery capital of the client. Assessing their social resources. Again, we have talked about family, friends, religious communities, mutual support groups, in the office or in the workplace. All this is very important as recovery support, and it influences the likelihood that the client will actually pull through their program and recovery. Assessing the social context, find out with whom does the client spend most of the time? With whom does the client use the substance? All this information is helpful. Find out whether the client lives with someone who uses substances. If they do, that then makes you know there is a negative recovery capital right there, and the client needs to work on that as a matter of urgency. How has the client's social network changed since the substance use began or escalated? You will discover that clients will tell you they had wonderful social networks, but as they began using substances and got more and more into substances, they probably have lost these networks other than the networks that use substances. And as you realize this, then you might want to plan their treatment in terms of a different setting. And you remember when I think it was in UTC too, when we talked about the various placement options, where you consider the problem plus the recovery capital. So as you're assessing and you pick this information, you'll be able to know whether this is a client that can go to outpatient treatment coming from home, whether this is a client that needs to be in inpatient treatment with intensive support, and so on and so forth. Now, the fourth domain, and very, very important, is something we call functional analysis. What does someone think functional analysis means? Yes, just from the English word of functional and analysis. We always say we start from the known to the unknown. What do you think functional analysis is about? Because we are being told that we need to assess the functional analysis. Yes, please raise your hand. That's Dr. Oko.
Yeah.
Yes, Dr. Oko.
It refers to what the person is able to do.
Just before you speak, Dr. Oko, I want you to move back a little. Yes, thank you, because of the vibration. Thank you. Please go ahead.
What analysis means what the person is able to do competently.
What the person is able to do competently. Thank you for your effort. Thank you for your trial. Another person, what is functional analysis? Any other answer? You can check for me, Kim, if there's anything in the chat. Yes, what is functional analysis?
In the chat, you have ability to do things.
The ability to do things. Okay, any other effort? Okay, so thank you very much. Functional analysis is actually borrowed from behaviorism, and behaviorists do believe that behavior always plays a role in people's life, that you don't just do anything without a reason. There is a purpose. If your child is a truant, they believe that that behavior we are calling truancy serves a certain purpose in the child. And if you want to change that behavior, you must understand what is it, what function does that behavior serve? For example, if your child throws tantrums every time you're in the supermarket or in the shopping mall, behaviorists will say, you need to find out what purpose does that tantrum solve, or does that tantrum, serve. For example, maybe the child throws the tantrum because when they throw the tantrum, the parent wants to save their face. So to save their face and the embarrassment, the parent buys candy for the child. And so the child discovers that every time I want to eat candy, all I need to do is throw a tantrum. So that behavior is serving a certain function in the life of that child. So in the same spirit with SUD, functional analysis is about asking ourselves or asking the client, what is the purpose? What is the role that this substance plays in your life? Now, you remember George was telling us that he uses, I think it was opioids when he goes to parties, just once in a while, just when he's in the party. He said it's not a big issue. He just uses that when he's in the party. So the question is, what role does that use of opioids serve for you in the party? And probably George might say it helps him to fit in the party. That is the functional aspect of that substance. So in this domain of functional analysis, we want to assess the role that each of the substances plays in the client's life. And this is important because then you can be able to help the client to meet those needs using a different strategy as opposed to using the substances. So for example, some of the functions that substances play in clients' life include the following. A client may use substances to change their mood. They tell you that I get very anxious, I get very depressed every morning. So to raise my mood, I use this substance. And I have had clients, especially in the university, who say that I use cannabis because if I haven't used it, I'm anxious. I can't speak to a lady. So to speak to a lady, I will use it and I will feel better. Another one told me that he uses cannabis to enhance his dancing. He goes to in my university, we have what we call a student center, recreational facility, where some alcohol is sold there. So he told me that when he goes there, he takes the alcohol because then there's music and he can dance better. And he says when he dances, when he's under the influence of alcohol, people tell him he's a real great dancer. So you can see that substance enhances something that he finds valuable. So it could be to change mood, it could be to change their thoughts, it could be to cope with certain situations. I also had a university student who told me that they use cannabis because, according to them, they had been diagnosed with schizophrenia and the medication wasn't working well. But someone advised them that if they use some cannabis, it will help them. And according to her, ever since she started using cannabis, she's doing better, according to her. So she uses cannabis to help her deal with her thoughts, which are disturbed because of her condition. So all these are clients' theories and myths and perceptions that we need to hear, because it is based on hearing this that we plan treatment that is client-centered. Now, why is it important to assess the 4 domains? First is that it helps us to understand the interrelationship between the 4 areas. Remember, we started by assessing what substances does the client use, how much, how, what context. Now we are saying in the functional analysis, we are asking, what is the purpose of using that substance? So we begin to understand the connections between the substances the client is using, where they are using them, what time they are using, how frequently, the problems they are causing them, as we do assessment in the 4 domains. And secondly, it offers us information that we can use to increase their motivation for change. For example, when we understand how the substance has affected client in a certain important area of their life, that was the domain about consequences. And then we also understand that the reason they use the substance is because it serves a certain purpose. So for example, you use the substance to enhance your dancing. But at the same time, you're saying because of using the substance, it has landed you in trouble with the law. So how are these 2 related? And you help the client to begin to see the connections and to begin to see or to get the reasons to change. And that's basically what this module is about. And I have 2 minutes. So maybe in the 2 minutes, I can have 1 question or 1 comment, particularly on these domains of assessment that we have talked about. Yes, anybody that has a comment on the domains of assessment? Which ones in your center do you assess? Which of those domains do you assess?
I miss the second domain. My internet went off.
So Dr. Oko, you do which one?
I miss the second domain.
The second domain, the one that was talking about the consequences?
Okay, okay.
Okay, anybody else? What aspects do you assess in your center, in your treatment program? So we are going to share much more of this in the LMS. We're going to be reflecting on what kind of assessments we do in our different programs and sharing on some of the things we think we can improve so that we have more comprehensive assessment. And then just to mention that beginning tomorrow, we're going to get back our client, George, and thank you, George, once again for accepting to be our client yet again. And we are going to be working on an assessment tool that is evidence-based, that is called the Addiction Severity Index. It does cover the domains we've talked about plus more. And so please make sure that you download it from the LMS. If you have any problems, speak to Kim. She's been waiting to assist so that we can have you with your tool. Now, because we tried this the last class when we had the assist, please make sure you have everything you need. You notice it was like a marathon, trying to talk to the client and check in our scores. So please make sure you have everything you need to make life a little easier. Preferably a hard copy of the ASI will probably be more useful. So thank you very much, and I hand it over to Kim.
Thank you, Beatrice. It's nice to see everybody. I'm missing you as I have Jessica do these calls. I apologize. She's wonderful, so but I apologize that I'm missing them. I'm going to send out a survey to ask you about that learning management system, the LMS, and how it's working for you. So it's just got a couple questions. I'm going to send that when I send the link to the Zoom meeting tomorrow. So look for that, and please do fill it out so that we know if you're having difficulties, what those are, if you like using it, etc. And I think that's it. If you don't have the ASI and you couldn't get it off the learning management system, do let me know before tomorrow so that you have it for class tomorrow. I think that's it. We'll see you tomorrow. Bye, everyone.
Good night.
Bye-bye.